So the wrong way is what dissuades us from doing a phakic IOL, ICL, IPCL, whichever. So what can go wrong and what should be right? So when the procedure can go wrong, we are worried about high vaults and low vaults. So calculation has to be absolutely correct and sticking to all the protocols. Post-operative IOP rise, not much. Upside down ICL or a phakic IOL is the biggest trauma that anybody can have in the early days. But believe me, it's not so difficult. Damaged ICL, rarity. We will show it in the OPL. I did this, I damaged it, and look, I had a heart attack and things like that. But it's a rarity, rarity, rarity. And if you do things the right way, it will not happen. Lens touch cataract formation, even the very seniors would tell you this again is a rarity, and it is very rare unless you've been really aggressive during the insertion of the ICL or the phakic IOL. Post-operative glare really doesn't matter so much. Pigment dispersion, rotation of a toric IOL, that can happen, but if it happens, it must be recorrected and you must take a call as early as possible. Now, look at this. This is just a small video which tells us that what is happening. Halka sa music rakhenge sab. See, this applicator has got stuck. The lens is stuck in the applicator. What could have gone wrong? The loading was wrong. Okay, so I did not hydrate the tip of the applicator well enough and thereby a partially hydrated, थोड़ा सा कम करके रखिए boss. The partially hydrated applicator actually impinged, it swelled up when it was in the cartridge, and that's why it was sticking to the haptic there. So again, a stuck ICL. What happens? Now, what happened to this patient is suddenly jerk and the injector contact lost. Okay, the ICL was right inside, but it had not unfolded. So we have a tough time here. It can fold this way, it can fold that way. Big concern that all of us have. So you have to be very careful which is the right way up, and that right way up is for the ICL is the leading right should have that hole. That's very important when you're not understanding. And please remember that even when you have 3/4 injected it and you feel it is wrong, just pull out the whole ICL which has been injected with the cartridge and it will be fine. You can reload it, the same one, and then again place it well. Now, having said all this, this is the right loading technique. Now, look at this. I'll be stopping the video midway also. Now, placing in the methyl cellulose in the cartridge, it should be half methyl cellulose, half BSS, and there should be a good collision between the two. So a stream of methyl cellulose, and then with the irrigation needle, you just have to irrigate so that the BSS more or less complies and is uniform. Then after that, placing the ICL, it has to be done, and please do it. ICL will not, they don't give the ICL in twos. The IPCL and other lenses, you have a second one in chance it drops, you have a second one to be there. So you must use it either on the trolley or on the field of view of over the patient, wherever if it falls you are able to pick it up. It usually will not fall unless again it becomes dehydrated, too much manipulation in the atmosphere. So once you take it in, then you place it in the hub just like that, and then you know which is the right side up, convexity 100% up, and you have to tweeze it in. The larger the ICLs, the 12.6, 11.6, 12.2, all these ones might take a little more of placing, pushing and pulling to have it nicely centered and convex. Convex, again, it should be nicely convex. It should not be tilted to one side or the other in the hub itself. Very important. Next is when you're coming in with the forceps, the osteo forceps which comes in from the front, you have to hold the ICL well, and there is a small hole in the ICL which you will be able to see. So you're loading directly under observation. They have to coincide and then start pulling. If you feel that it has not coincided and you're actually gripping only a small part, you have not gripped, please re-grip so that there's a good pull Now, with the pull inside, there also should be a slight movement outside. So the hub going outside, the pull going across. So thereby a very smooth glide of the rotate of the ICL that is going in round, it comes to the tip, right? So if you lose grip and if it is only halfway, you can really push it back again, nicely re-grip and take it up. So when this is done, then you have to place it in BSS while you're doing the side ports and the main port. Now, you have done the side port, main port, all is done. Now you're implanting it. Now here, the wrong way to insert. So this was one of my trainees, and it is going in. You have to be very sure where the leading. Now she has gone beyond the where she is able to see well. She's concentrating only on the main port. She's not actually seeing where the leading haptic and the hole. And what we are trying to do is wait, stop, but goes in. Okay? So now that it goes in, what is to be done? What is to be done? Why not rotate it? Never do. Please never do rotations. Please never do rotations. It should not be rotated. Please remember there's just 3 millimeters of space there. You do not have that aphakic 6 millimeters there. So it has to be taken out. So once you are sure the taking out is not so difficult, you have to grasp it well. It will come up in one piece without a damage. The same lens can be placed in once again. It's not so difficult. So do not get scared. What is going to happen? Cataract is going to ensue? Nothing really. And this time it should go in well. And again, the placement. You have to see, look at that, unfolding very slow. And you must see that, look at that, right end haptic, the hole. That's your point where you have to see. Up to that, please just hold on, don't push it blindly, right? So now, improper tucking. Now this will happen in the initial cases. How to tuck the haptics? Only initial cases it will happen, so don't worry. So it has to be tucked the right way also. Now here you place in viscoelastic because you would have lost viscoelastic, and you have to place in the viscoelastic, and then from the side port with the instrument you have to go right in. Now she is not going right in, she's just going halfway and trying to manipulate. Possibly, a little more viscoelastic needs to be put. See, all these steps are being shown so that one understands that what should be done. See, you should not be pulling there. It's not required. The tip of the haptic has to be negotiated. You need to go to the tip of the haptic. Now it's the right way. Now just a quick dip and it will just sink into that space between the pupil and the sulcus. Right. So this is important. Tucking is important. Should not do it blindly. And again, this is not required. You need to negotiate right to the tip only, and it will go in very smoothly. So inserting the IOL, so put viscoelastic on the top of the lens to get more room, manipulate to the periphery via the paracentesis, do the distal haptics first, the pupil is maximally dilated. Again, distal haptics best negotiated first, and then the proximal haptics, and avoid going across the central lens. Now this is the correct way. So again, what's very important also to make these paracentesis, to make the side ports very important. Please remember it's a phakic lens there, a virgin lens is there. Let us not be so fast as we do in cataracts. Be very meticulous, and you may not put the whole blade inside. Please don't. You can just put a tip, extend, tip, extend. That means then you're not going straight in. In case the patient moves, in case something happens, you still are safe. Right. So now this viscoelastic is very important. It should be full fill. It should not be too much. It should be optimal. So when the strands are coalescing together, that is supposed to be optimal. If it's too tight, then you have difficulty in manipulating, and the lens opening also. So here you are. Now I'm going to stop here. Now look at this. So actually it's going in sideways. What it has to come is, so you have to twist your wrist. So this is a very important maneuver and that has to be done. So once you twist your right wrist, so it's going in sideways but doesn't matter, it's going the right way. Oh, acha. So this is important, so I'll show it. It's a 1 minute video only. So this is yeah. Again, that dip must be there in the main port so that you have a nice and tight. Because remember, it's a 3.2. You, in fact, might increase the main port a little more also. Does not matter. It's not. You're not going to create a lot of astigmatism. But you have to be very gentle and smooth in the placement. So now once it goes in, it's going on sideways. It's all right. It doesn't matter. So you just, it will come in and shift and look at that. That is the right way to tuck. Just that, just going in right to the tip and then doing it. Here again from the main port right there and gently. Now too much of viscoelastic, it might go behind and then the pupil might be coming up, the iris might be popping out. And removal of the viscoelastic, very important. Please do it meticulously. Please remember. And a hydration through the tip, through that central hole. Best not to be done. If you want to do it, you can do it, but just for just a few seconds so that you just wash away a little. Because if a jet goes in and impinges on the anterior capsule, then there's a literature that it has produced cataract. So be very gentle, but as much as possible removal of the viscoelastic. Thank you very much.